Good morning, everyone. This lecture is about Meniere's disease, which is also called as endolymphatic hydrops. So, what happens in this condition, or um, of course, like this condition is related to the ear, and to be more specific, this condition is related to internal ear or the inner ear. This one is characterized by vertigo, um, ringing of the sounds in the ear, which is tinnitus, and sensory neural hearing loss. So, Meniere disease or idiopathic endolymphatic hydrops, you can see it's a disorder of inner ear associated with symptoms which I told you, and also there is sensation of oral fullness. Now, a brief introduction, but going into the pathology, what they found basically is some distortion in the membranous labyrinth, some changes in the anatomy of the membranous labyrinth, and there is too much endolymph they found, as well as like they found there is bulging of the Risner's membrane, and saccule may come lie against the stapes footplate. So simply you can see over here uh, in this photograph, like these are the things what they found, by the way. uh, Now, of course, like these are the changes you can see over here. uh, the depiction you can see here. Note this one and note this one. So this one is like the normal one, and this one is like the distended one. Okay. So anyhow, etiology. So to talk about the etiology of this condition, of course, one thing is clear: like there is the distension of the endolymphatic system. Uh, Now, either there could be increased production of the endolymph, or there could be defective absorption. So, like most of these conditions, when there is some fluid is accumulating in any area, so of course, like either it's increased production or decreased absorption. So this endolymph is basically secreted by uh, stria vascularis, and this one basically uh, is here. Like when we do the cross section of the cochlea, by the way. So what we found is like uh, this is the membranous labyrinth, where like all the central lymph is filled. So to tell you the cause for this one, like the etiology, you see there is defective absorption of endolymphatic sac. So a lot of things are written you will find over here, like poor vascularity, or less absorptive tubular epithelium, or increased secular fibrosis. Okay, so whatever is written over here, or whatever will be written over here, like there could be allergy, spasm of the internal auditory artery, sodium and water retention. What else? Basically, the exact etiology of the Meniere's disease is not known, but what is there? Like there are various theories, you can say, which are in circulation. You can see over here. Okay, uh, sorry. There are various theories which are there to explain the thing. For example, some of the theories explain why there is defective absorption. Some of the theories explain there could be sympathetic overactivity resulting in the spasm of the internal auditory artery, and sometimes there could be some uh, allergy. Okay, so and in this allergy, of course, like that, it affects the inner ear, which is the shock organ simply. Okay, so uh, now what they found, like many people who have many disease, many of them they do have allergies. Sodium and water retention could be one of them, and hypothyroidism. Okay, because in very few of the patients, the Meniere disease is secondary to hypothyroidism, or autoimmune or viral etiologies can be there. So anyhow, like all these things can be there, but the exact etiology is not known. Okay, that's the important thing to remember. Okay, now endolymphatic high drops or Meniere disease. These are all the things: the genetic, infection, vascular, dietary, allergy, autoimmune, endocrine, autoimmune. Like all this causes can lead to endolymphatic high drops, and which will lead to episodic vertigo, fluctuating hearing loss, tinnitus, and fullness. Now, to talk about the clinical features, um, basically it affect the people of in fourth to fifth decade, and mostly uh, like over here the male and female ratio is written equal, but like there is slightly more prevalence in male uh, than the females, and the vertigo, which is there, what happens is like it comes in like suddenly, abruptly, and the patient they feel like they are rotating, and then this these attacks they keep on they come in clusters. Okay, so sometimes whenever this cluster is there, so what will happen, like they have vertigo for a few days, and then there is a remission, and the person they don't have any symptoms for, you can say, could be months or could be years without any episode. So it comes in episodic form. So now, of course, whenever there is attack, of vertigo, it is associated with other symptoms as well. For example, vomiting and nausea, nystagmus, and things like this. And the important thing, most of the time there is no warning sign before these attacks. Rather, they come like all of the sudden. Okay, and whenever they have these attacks, what they think is like the patient they describe it like, of course, vertigo, that they have vertigo. They say like they feel like their ear is full, or you can say oral fullness is there. So um, many of them they show this Tullio formula phenomena. No, what is Tullio phenomena? It is simply uh, sometimes the loud sounds, it can produce vertigo uh, in the patients who have Meniere disease. We call it as Tullio phenomena. So now, why it is like this? Because simply you can see like they are very closely placed together. So the loud sound can, you can say, irritate that. So that's why it could occur. The other feature is like the hearing loss. So whenever the patients they have attacks, they have hearing loss, and once the attack is gone, the hearing improve. But the important thing to remember over here is that chronically, because when they have multiple attacks, they have some hearing loss. So you can say like with every attack, it adds up some sort of um, hearing loss. Okay, so, or you can say like the hearing loss is progressive but slow. Okay, so this is one of the feature, and then there is tinnitus, and the tinnitus is like the ringing of the sound. We already discussed this thing, and whenever like they had attack, they had tinnitus, though it can persist even without attacks. Okay, so these are the features of this Meniere's disease, and what happens, like how we diagnose them. You can see over here very, very, very uh, good way or easy chart to for the diagnosis. So what they say, like, see the definition: certain Meniere disease when the uh, someone who have definite Meniere disease plus histopathologically confirmation, then there is definite Meniere disease, two or more than two definitive spontaneous episodes of vertigo 20 minutes or longer, auditometrically documented hearing loss or at least one occasion on at least one occasion, and tinnitus or all fullness in the treated ear, provided you have excluded the other causes. And there could be probable Meniere disease when someone have one definitive episode of vertigo with hearing loss documented, tinnitus, oral fullness, and possible Meniere disease. Now, of course, we say like this is the section which is the most important one in this case. So, of course, like what are the testings you can do? What are the examination you can do in these patients? You can do otoscopy. You can check for nystagmus. You can check the tuning fork test like Weber's and Rennie's test. You can do the auditometry, okay, audiometry. And as I told you, there could be different audiometry like pure tone audiometry. There is speech audiometry, and nowadays there is electrocochleography as well. Okay, she can do. So uh, we can do calorie test. So you can see over here the calorie test. It is uh, when we do calorie test, which shows reduced response on the affected site simply. So we can do like glycerol test as well. And glycerol is a dehydrating agent, and whenever we give it to the patients, it reduces the pressure in the endolymph, and they get improvement in hearing. A lot of explanation is written, over here, like what is SPAP ratio. Like I don't think so. You have to even go through that. Why? Because they're not important. But just to tell you, like, what is this SP or AP? This is like when they do cochleography. Okay, so it gives like some waveform type of thing. So this is the ratio of one wave with the other one, SP or VP. So SP is basically sumating potential and AP is basically action potential. So there is ratio for these two. So now, okay, leave this thing. Okay, there are some variants of this condition as well. You can see like there is a cochlear hydrops in which there is no vertigo. There is something called as vestibular hydrops when there is no hearing loss. So cochlea, remember cochlea is the one which is deal with the which function is hearing. So simply cochlear hydrops like they have the hearing problem but no vertigo, and vestibular hydrops like they have the vertigo but no hearing loss. Okay, so drop attacks, these are also variants. And what happened like these patients, they have a sudden drop attack but they don't lose their consciousness, and there is no vertigo, there is no hearing loss in these patients. Okay, so that is like drop attacks. And then there is Lermoyer's syndrome. So what is that like in this one, the you can say it is the opposite or reverse of Meniere's disease, in which like there is hearing loss followed by vertigo. So in Meniere's disease there is vertigo followed by hearing loss. Here there is hearing loss followed by vertigo. Okay, so now how we treat that. uh, okay, so how we manage that thing. Okay, of course, like the management in this one is it's a chronic condition, so there could be management of the acute attack versus like what is the chronic management. So, um, first of all, in acute stages, what we do, we uh, have to control that episode of vertigo. So we can use some medications which are basically called as labyrinth sedatives. Plus, they have a lot of nausea, vomiting. Plus, antiemetics, they help a lot in this case. Or you can go for a carbogen or histamine drip. So, what is basically carbogen? Uh, Carbogens is like inhalation of carbon dioxide. It is called as carbogen. So basically, what is that? The like this one is a vasodilator, so it improves the labyrinthine circulation. And histamine drip can be used. And when we give histamine to these patients, it helps controlling the acute attack. Labyrinth sedatives and antiemetics are a lot. Okay, so like there are different drugs which are given in this one. Like prochlorperazine. So now why I'm naming this prochlorperazine, because there is a tablet which comes by the name of Stamatil, almost almost in many countries, not in China, of course. So Stamatil, like even many lame, like the general population, they know that whenever like someone have road sick, like what you can say, that sickness, whenever motion sickness, whenever you are traveling in car or you're going to some hilly areas, people have nausea, vomiting, stuff like this. So they know like they have to take Stamatil. So for that, you know, they can be used. So of course, like this is the management of the acute attack, but whenever like the patient is out of acute attack, what we have to do is like uh, we have to go through a lot of measurements like low salt diet. Okay, so we can ask them, or we can put them on diuretics. Okay, we can ask them to uh, limit their water intake as well. Okay, now we ask them to not take too much caffeine, nicotine, alcohol, and tobacco. By the way, smoking cessation is very important in this one, because nicotine, it causes vasospasm, and this is a very important step you can take, because smoking cessation gives a lot of improvement in these patients. So this thing, and a lot of education should be given to these patients, because they may have attack anytime without any prior symptoms. So that's the reason we ask them to avoid any, um, like if their job is something like this, like they are working next to heavy machinery, so change that job, or avoid risk taking behavior, avoid sports like swimming, things like this, avoid flying as well. So all the things. So these are the things which we can do, but chronically, what we do is like we put them on vestibular sedatives. Okay, so I can add a slide over here. So what are vestibular sedatives? Like again, I told you one of the drug name is Stamatil, or like what this one have is prochlorperazine. So this one is like a very important thing which we can do. So we can put the patient on this thing. Okay. We can put the patient on chronic treatment, you can say. We can put the patient on some vasodilators like nicotinic acid. Okay. Nicotinic acids can be given, plus we can give them beta histine. Okay, so they can be given. We can put the patient on diuretics. Now diuretics are many, right? Now free furosemide, and uh, there are many diuretics which are available. One of the drug which we can put them on is propanthelene bromide. So propanthelene bromide, it's also a vasodilator, and try to find out if they have any allergy and tell them to avoid that, of course. Okay, so these are all the things which we can do, but sometimes, the condition cannot be treated even by this thing. Then we go for some destructive or surgical procedures, like there are some non-ablative procedures, and then there are some ablative procedures which we can do. So here it's written over here, like, endolymphatic sac surgery. So of course, like in this one, they can create a shunt which is going to take out the lymph, uh, in the subarachnoid space or in the mastoid space. So non-ablative procedures can be many, like uh, intratympanic steroids can be given, sacculotomy or cochleosacculotomy can be done. This one is also called as fix operation. And what they do, like they puncture the saccule with the needle through the stapes footplate. So this is like called as fix operation, right? So this thing can be done. A lot of ablative procedures can be done. Now remember, guys, gentamicin or gentacin, they are the same drug. They are vestibulotoxic, so they can give an injection of this drug directly into the uh, inner ear, and which is going to destroy this one, right? So this is one of the things they can do. So there could be, you can say, selective vestibular nerve sectioning can be done. Okay, of course it's an ablative procedure. And nowadays, of course, like the ultrasonic destruction of the vestibular labyrinth is also available. So that's a good thing. So these things can be done. We can section the nerve, but of course, like at the cost of you will not be having this function intact. Like when something went wrong, you take out the connections of that. So ultrasonic destruction of the vestibular labyrinth, cryodestruction or labyrinthectomy, of course, like removal of that structure can be done. And recent advances, there are many: decreased by pulsing pressure in the middle ear. There is Menieres device, handheld air pressure generator that the patient self administers. And like these are the new recent advances in this one, which are used. So destructive procedure simply when you are going to destroy that area, right? So this is how they go through that. So guys, uh, the last thing which we are going to discuss today is vertigo. Okay, and vertigo and dizziness. What is vertigo? Perception of abnormal movement. It could be peripheral or central. Okay, so yeah, many people, remember when in the real, like in the practice, when a patient comes to the doctor and he is saying, like, doctor, I feel dizzy, or I have vertigo, or I have the sense, or like I am going to fall off, or the things are revolving around me, or I am revolving in the rooms, whatever is the case. You have to first of all see, like, either the patient have dizziness or vertigo. So dizziness is a non-specific term, could mean vertigo, weakness, syncope, giddiness, pre-syncope, anxiety, and all this stuff, right? So vertigo, again, like this is like the, what you can say, uh, different things. What is syncope, like, which is the transient loss of consciousness due to global hyperperfusion of the brain. We call it as syncope. So now the important thing over here, uh, we have discussed this thing, already. What is the cochlea? What is the labyrinth? And of course, like, these are the one which are controlling the balance in the body. And now, okay, so now, whenever anyone have vertigo, it could be peripheral and it could be central. It could be peripheral, it could be central. So you can see over here, these are the different causes of vertigo, right? So peripheral one means like the vestibular have the problem. Okay. So vestibule, or like it could be eighth cranial nerve. And the central one is when the central nervous system is the one which is affected, like the brainstem or any central nervous system problems. See, like vertigo, differential diagnoses are many. It could be benign, paroxysmal, positional vertigo. So what is this one? Like, these are the people who have vertigo when their head is placed in some specific or certain positions and they don't have any hearing loss. And how we diagnose this thing, there is uh, like the doctors, they move the head in some specific position and it can bring uh, the vertigo, right? And if you know like what are those procedures, watch video of Hell-Pike procedure or Hell-Pike maneuver, Dick's Hell-Pike maneuver. So see, like, she's turning the head 45 degree and she's putting her dam down. Like, for like, this is all the details. Hell-Pike maneuver. So like this one, we bring the patient like this one, then put his head down like this, and then twist it around like this. So it brings a vertigo, right? This is called as Dick's Hell-Pike maneuver. And when we diagnose a patient with BPPV, we ask them to perform a maneuver called as Appler's maneuver. So again, like, YouTube is the best source. You can watch that one. So BPPV was one of the cause. Then there could be labyrinthitis. Labyrinthitis is what, like the inflammation of the labyrinth. It could be uh, due to any infections. It could be due to any inflammatory causes. So these are the causes: C, acute, suppurative, serious, toxic, and chronic. Then there could be vestibular neuritis. So what is vestibular neuritis? Like, these are the patients who present with severe vertigo, okay, but they don't have any cochlear system, like no hearing problems. Why? Because there is just vestibular neuritis, right? So the attacks can last for around 2 to 3 weeks, and most of the time it occurs after a viral infection. Then there could be vestibular ganglionitis, which the name shows, like the ganglion is inflamed in this case, right? Then there could be Meniere's disease. We have discussed that. Acoustic neuroma is the tumor of the eighth cranial nerve, right? And whenever like the patient, they have this thing, they have vertigo, and sometimes like the nerves which are around that eighth nerve, like facial nerve or ninth nerve, all this one can be also affected due to pressure. There could be perilymphatic fistula or perilymph fistula, sorry. Okay. So in this one, the lymph is leaking, that's it, through the oval window, through the round window. And this most of the time occurs after stapedectomy when they do a surgery, like for otosclerosis. So, or sometimes it can also occur due to barotrauma. Okay. There could be vex infection, there could be CNS infection like tuberculosis and syphilis, of course, like the central causes, tumors, central causes, cerebellar infarct like strokes, central cause cerebellar hemorrhage, central cause vestibulobasilar insufficiency, ICOR-PICA, like posterior inferior cerebellar artery syndrome, which is also called as Wallenberg syndrome, multiple sclerosis, basilar artery migraine, hypothyroidism, hypoglycemia, traumatic or hematologic. So see, like all these things are, you can say, the central causes, right? And they can present with vertigo. So anyhow, guys, whenever anyone presents with vertigo, first of all, you have to establish either it's a true vertigo, check for the autonomic symptoms, check for onset and duration, auditory disturbances, neurologic disturbances, like you are differentiating between either it's central or peripheral. Is this a syncope, abnormal eye movements like nystagmus, history of trauma, past medical history, So you will take a good history, then you will go for the examination. You will rule out impaction of the wax by looking in the external auditory canal, vesicles. You will rule out otitis media. You can go for pneumatic otoscopy, and you can do hearing test, Weber-Rennie test, nystagmus, Dis-Halpack maneuver. You can do for BPPV, blood pressure in both arm, orthostatic violence. You can examine the cranial nerves, pupillary responses, like all this one to rule out the central causes. So now, see, for example, if you found that someone have hearing loss, tinnitus with this thing, it means the problem is in the inner ear. Someone who have facial weakness, it could be acoustic neuroma. Someone who have like loss of consciousness with memory disturbances like hemiplegia, hemiparesis, of course, it's central cause. Someone who have cerebellum signs as well, central cause or cerebellum cause, right? So this is the difference between the central vertigo and the peripheral vertigo. Peripheral one, it occurs suddenly, it is more intense, it is paroxysmal, and it is exaggerated by movement. There is more autonomic features. Um, it is unilateral. The nystagmus is either horizontal or rotatory. It is fatigable. The auditory symptoms will be present. Tympanic membrane may be normal, but CNS symptoms will be absent. So these are the central one. So these are the other tests which we can do. Now, guys, okay, okay, these are the explanation of all these things which I talk about. Of course, I will give you the slide like acoustic neuroma. See the tumor you can see over here, the tumor you can see over here, the tumor you can see over here, right? And again, like central vertigo, all the causes are written right over here. So anyhow, guys, the important thing is now how to deal with vertigo. By the way, this one is also given here. This is the Apples maneuver, but better to see like on YouTube. So the management based on the cause. So of course treat the cause. So either it's a central one, either it's a peripheral one, okay, and either there is neurological signs are present. If there is suppurative labyrinthitis, give it, admit and IV antibiotics. Toxic one, stop the offending drugs. So of course, like the management, it deals on the cause. For BPPV, give them Apples maneuver, treat Meniere disease if it is the cause. But the mainstay of peripheral vertigo management is again antihistamines that possess anticholinergic properties. Okay, so we give them these drugs. You can give them vestibular sedatives, right? This is the thing. Okay, guys, so this is the vestibular system with its connection, how the things work. Okay, so anyhow, in this slide you will found like again this is the sign and symptoms of the peripheral one as well as central one, and these are the list of the drugs. Sorry, these are the testings, but these are the list of the drugs. Sorry, there is no list of the drugs in this one, but like the explanation of all these things, right? So list of the drugs you can see like right vestibular sedatives or all this one you can get the list of the drugs. Okay, thank you so much for listening, guys. This is the last lecture for the ENT, and that's all. So I will see you in some other subject.